Good evening. My name is Kevin Bergerson, and I'm the Programs Assistant Manager for the Colon Cancer Alliance, and I would like to welcome everyone to latest in CRC findings from the 2016 ASCO Annual Meeting webinar. Tonight, our guest speaker is Dr. Christopher Liu, and he will be reviewing some of the latest trending information coming out of the June 2016 American Society of Clinical Oncology, ASCO, Annual Meeting. He will explore what these advances in research findings mean regarding treatment, patient care, and survivorship. In addition, you will also have the opportunity to engage in a question and answer session with our presenter and our two expert panelists. As a reminder, this webinar is being recorded, and all registrants and attendees will receive a link to where we have posted the webinar recording for future viewing. Before we get started, I'd like to remind everyone that neither the Colon Cancer Alliance nor our presenter are giving medical advice, and no doctor-patient relationship is intended or established. You should always seek in-person medical advice and make medical decisions together with your individual clinician team. Before I introduce our guest presenter, it's my pleasure to introduce our two expert panelists, Dr. Laura Porta, Medical Advisor and Senior Patient Advocate for the Colon Cancer Alliance, and Dr. Tom Marsolais, PhD, well-known oncology drug researcher and patient advocate. Dr. Laura is uniquely positioned to serve as the Colon Cancer Alliance's medical advisor. In 2003, Dr. Laura was in her second year of her pediatric residency when she was diagnosed with stage 4 colon cancer. In 2006, she became cancer-free after many medical interventions. Dr. Laura's medical background, battle with cancer, humor, and honesty uniquely position her to share her message of hope and survival with the community. Dr. Tom Marsolais has performed oncology drug discovery research for more than 20 years, including co-inventing an FDA-approved drug for non-small cell lung cancer. He has currently incurable stage 4 MSS colorectal cancer, first diagnosed in 2012. In addition to being a very active CRC patient advocate, Dr. Marsolais writes an information and hope-filled personal blog at the intersection of cancer drug discovery science and stage 4 patient life called Adventures in Living Terminally Optimistic. Dr. Laura and Tom, welcome. At this time, it's my pleasure to introduce our guest presenter for this evening, Dr. Christopher Liu. Dr. Liu joined the University of Colorado School of Medicine faculty as an assistant professor in July 2011. He trained in internal medicine at the University of Colorado, where he also served as chief medical resident. He completed his fellowship training in medical oncology at the University of Texas MD Anderson Cancer Center and served as the chief medical oncology fellow in 2010. Dr. Liu is a member of the Developmental Therapeutics Phase 1 clinical trials and gastrointestinal medical oncology program. These comprehensive programs include multidisciplinary cancer clinics, tumor boards, and research endeavors. Dr. Liu is interested in resistance mechanisms to targeted therapy in GI cancers, and he was awarded the Conquer Cancer Foundation Career Development Award to study targeted therapies in colorectal cancer. Dr. Liu has a unique gift of conveying complex medical and clinical trial information into easily understandable terms. I think you're going to enjoy his personal style and informative presentation this evening. Dr. Liu, welcome.
Well, thank you so much, Kevin. Appreciate the very kind introduction, and also thank you, a big thanks to Dr. Marsolais and Dr. Porter for not only joining us, but for also helping design the slide deck that you're going to see. The 2016 American Society of Clinical Oncology holds its annual meeting every June in Chicago, Illinois, and at that meeting there are literally thousands of research presentations that are given over the 4-day course of the meeting. It's very difficult to go through all of those research studies and find what is the most groundbreaking and exciting abstracts, and I believe that the experts that have put together the slide deck have been able to successfully do that. So I'm very excited to present some very neat and groundbreaking research regarding colorectal cancer. So in regards of what we're going to go over for the next 20 minutes or so, we want to talk about some definitions because we're going to use some scientific terms to really show what the research is around particular types or subsets of patients with colorectal cancer. And so we're going to discuss several very promising clinical trial results with immunotherapy. Now, these are not very large, humongous trials that sponsors will then send to the FDA, but they are groundbreaking in terms of their results and the promise of immunotherapy for colorectal cancer, and we'll go through that. We'll discuss a trial looking at the differences between right-sided colorectal cancer and left-sided colorectal cancer, particularly in the metastatic setting. We'll go over some new data on detecting circulating tumor DNA. So in other words, being able to detect tumor DNA in the blood and how that might help us in terms of discovering what a patient's risk of recurrence is, and then we'll touch briefly on also the benefits of a second opinion. All right, so we'll start off with some definitions. So chemotherapy is a term that most people equate with cancer, and that is that a treatment that essentially uses any drug to stop the growth of cancer cells, either by killing the cells or stopping them from dividing. The problem, as most people know with chemotherapy, is that while it may be effective against a particular cancer, it's unguided. So it's almost like dropping an unguided bomb onto a target. You might be able to hit your target, but there's certainly collateral damage associated with that. So we also know that chemotherapy can affect normal cells, and that's why patients sometimes get very tired, sometimes they get nauseous, sometimes they lose their hair. In contrast, targeted therapy is a type of treatment that uses a type of therapy or medicine that can identify and attack specific types of cancer cells with less damage to normal cells. And so we often use targeted therapy to hit a particular growth factor pathway. And while these targeted therapies can sometimes be effective against colorectal cancer in particular, it can sometimes lead to less side effects because you're trying to deliver kind of a smart bomb, to use that analogy again, as opposed to an unguided bomb. But these targeted therapies still do have some side effects associated with them. And certainly what we know is, from 1957 to 1997, for 4 decades, there's literally only one drug to treat colorectal cancer, and that was 5-fluorouracil. And so over the last 10 to 15 years, we've seen a virtual explosion of drugs used to treat colorectal cancer. And this is a combination of different chemotherapies like 5-fluorouracil, oxaliplatin, and irinotecan, but also targeted therapies. Some drugs that target blood vessels like bevacizumab, other drugs that target something called the epidermal growth factor receptor pathway like cetuximab and panitumumab. So certainly more drugs over the last several years than we've ever had before. But of course, some of the more exciting developments in the world of cancer therapy has been immunotherapy. So any immunotherapy is a drug, it's a type of drug that's used to essentially either stimulate the body's ability to fight the cancer on its own, so stimulate the immune system. And immunotherapy has also been used to help the body fight off not only cancer, but also infection and other diseases as well. But the idea or the concept of this is essentially to be able to utilize a person's own immune system to fight the cancer, because certainly one of the major hallmarks of cancer is its ability to evade the body's natural defenses or its immune system. So I want to talk about some terminology that we're going to use to talk about immunotherapy. And we're going to focus on 2 terms in particular, one called microsatellite stable colorectal cancer, or MSS, which represents 95% of our patients with metastatic colorectal cancer. So this is a vast majority of patients. And I'm going to describe this as mismatch repair proficient. We're going to go through this very, very carefully. But essentially any tumor that has the ability to repair mismatches in DNA. I also want to contrast that to MSI High colorectal cancer. So you'll also hear this called microsatellite instability or mismatch repair deficient colorectal cancer. And this is a minority of the patients that have metastatic colorectal cancer, only about 5%. But this represents any colorectal cancer that lacks an ability to repair mismatches in DNA. And so what does that mean? So the example that I like to give is if a patient, or if somebody told you to take War and Peace and transcribe it word for word, letter by letter on a word processor, and you had to go through the 1,000 pages or so and transcribe every single letter, you're bound to make mistakes. You're bound to make typos. Much in the same way, when DNA replicates, it can also make a typo or a mismatch in the DNA. And so just like a word processor has spell check so that we can fix those typos, our DNA has a similar mechanism called mismatch repair. And that is a series of steps that essentially means that you have to unwind the DNA, replace the mismatched pair, and then essentially replace it with the correct pair, and then wind the DNA back up. And so most everybody, so 95% of our patient population with metastatic colorectal cancer has this ability to correct mismatches in their DNA. But when you lack this mechanism, if there's a mutation in any of the genes that are associated with this repair mechanism, it's like transcribing War and Peace, but not having spell check. And so comparatively, when you have a patient with mismatch repair, colorectal cancer, or microsatellite stable colorectal cancer, your tumor may have about anywhere from 30 to 70 mutations in it. If your body and your tumor lack the ability to repair mismatches in their DNA, we call this MSI High or macrosatellite unstable colorectal cancer. And in this case, those tumors have over 1,500 mutations. So there's a vast, significant increase in the number of mutations that you have per tumor. Why this is important is because MSI High colorectal cancers have a lot of mutations. And when your tumor has a lot of mutations, the immune system actually starts to recognize whether or not there's something that they should attack. And so what the pictures that I'm showing you here are actually MSI High colorectal cancers that actually have T cells or immune cells inside of them. And so the analogy I like to use here is that you have a party, so you have the venue, you have the people there, but there's no music to start, so nobody's dancing. So essentially the tumor infiltrating T cells are present within the tumor. They're just not activated to kill the cancer. So they know that there's something there. They're just not activated to kill the cancer. And so what's interesting is that the immunotherapies that are currently being developed take the brakes off the immune system. So essentially, to use that analogy again, you have the party, you got the people there, the immunotherapy is just there to start the music, and you get the T cells dancing, and then hopefully the idea is that the T cells begin to recognize the cancer and are able to fight it. So the first study that we're going to show you is the results of using one of these immunotherapies that take the brakes off the immune system called a PD1 inhibitor. And so this PD1 inhibitor has a drug name, and it's called pembrolizumab. And they looked at this in patients with colorectal cancer. And we want to show you the results of this because they're fairly striking. What I'm showing you is the best radiographic response, so a CT scan response when we're measuring tumors in patients with both MSS colorectal cancer or mismatch repair proficient or MSI high colorectal cancer, mismatch repair deficient colorectal cancer. So the microsatellite stable colorectal cancers are in red. The microsatellite unstable colorectal cancers are listed in green, and you can clearly see that the patients with MSI high colorectal cancer, the bars in green, are clearly having a bigger tumor response to the PD1 inhibitor, pembrolizumab, compared to the microsatellite stable colorectal cancers. And as you can see, and I'm not sure if you can see my arrow or not, but there's some patients here who have had a complete response to therapy, which means that their tumors are no longer visible by CT scan. When you look at the time to tumor growth, we call this progression-free survival. How long does it take for us to witness tumor growth on a CT scan? Again, the green line represents the patients with MSI high colorectal cancer, and there are two takeaways from this graph here. One is that MSI high colorectal cancer seems to do much better with immunotherapy compared to microsatellite stable colorectal cancer. As you can see, these two curves are very, very different. The other thing that I want to show you is that there's a plateau to this green curve, which means that there are patients that are reaching 2 years plus of not having any tumor growth at all. So for some of these patients, the response is very durable, and what we mean by that is that it's very long lasting. So the take-home point from this clinical trial is that PD1 blockade with the immunotherapy, pembrolizumab, is very active in patients with microsatellite high colorectal cancer. and that it does not seem to be as effective for microsatellite stable colorectal cancer. In fact, there were no responses seen on this trial for MSS colorectal cancer, microsatellite stable. There are complete and durable responses seen with this drug in more than 50% of the patients. Interestingly, 5 patients have reached the 2-year mark and the drug has been stopped. So it actually gives us an option, the ability to actually see whether we can just stop the therapy, and do the tumors not ever come back, or do they not ever grow? And I think that will be an interesting analysis going on in the future. So the biggest take-home message here is ask your doctor about MSI High testing. Has it been performed on your tumor? And if it has, what the results are. The other trial I want to show you regarding immunotherapy and MSI High colorectal cancer is a combination of 2 immunotherapies. One is called nivolumab, which works in a similar fashion to pembrolizumab. It's a PD1 inhibitor. Another drug is called ipilimumab, which is somewhat difficult to say, but it's a different mechanism of action. It's a CTLA-4 inhibitor. It also takes the brakes off the immune system. And so what I'm showing you here on this figure are the mechanisms of action of both ipilimumab and nivolumab. So these are 2 drugs that are essentially trying to take the brakes off the immune system so that the immune system can then recognize the cancer and then fight it. And again, this is a study done only in microsatellite high colorectal cancer. So they compared essentially 2 groups of patients that received the PD1 inhibitor alone, nivolumab, and patients that received a combination of the 2 immunotherapies, nivolumab and ipilimumab. And the take-home point here is that, again, on the graph on the left, you're still seeing great responses to the PD1 inhibitor nivolumab alone. But when you look at the graph on the right, the patients who received both drugs, nivolumab and ipilimumab, seem to actually do better. So instead of just 56% of the patients with significant tumor reduction, on the graph on the right, with a combination of both drugs, you're actually seeing an 81% reduction, or 81% of the patients with a significant tumor reduction. So it does look like, again, this is an early look at this trial, but again, the combination of both immunotherapies appears to be more effective than just one immunotherapy by itself. And so the take-home points from this study, both nivolumab and ipilimumab demonstrated encouraging activity, again, in patients with MSI high colorectal cancer. Some of the responses appear very long-lasting, and of note, this trial is still recruiting patients. So I've shown you 2 studies looking at immunotherapy for MSI high colorectal cancer. In one of those studies, I also showed you that the responses were not very promising in microsatellite colorectal cancer, or microsatellite stable colorectal cancer. So what about the other 95% of our patient population that has intact DNA mismatch repair or microsatellite stable colorectal cancer? So we want to show you results, again, from a very early phase trial, but looking at a targeted therapy, one of those drugs that targets a growth factor pathway in colorectal cancer in combination with this another drug called atezolizumab, which is a PD-L1 inhibitor. It's an immunotherapy drug. I want to show you the rationale behind this. So a lot of the research that's done is actually done in a lab. And so we want to be able to test whether combinations of drugs are effective in tumors in the lab. And if they are, then that gives us a rationale to then try something that we believe will work in patients. And so what these investigators did was give colorectal cancer cells a targeted therapy called a MEK inhibitor, and this drug is called cobimetinib. And what they saw was when they treated these tumors with this targeted drug, they actually saw upregulation of tumor-infiltrating T cells. So what they saw was, well, they give the targeted therapy, maybe it affects the cancer growth, but what they were seeing were actually immunogenic or immune responses in the tumor. And what they noted was that when they combined this targeted therapy with an immunotherapy, what you're seeing on the graph on the right is that the tumor growth was significantly inhibited, not with either drug alone, but the combination of the 2 drugs seemed to work together to inhibit tumor growth. So this is the results from a phase 1 trial where they treated essentially 21 patients with colorectal cancer with a combination of this targeted therapy, cobimetinib, with the immunotherapy, atezolizumab. And what they saw were a significant amount of patients, and you're seeing that on the left side of this graph, where the patient's tumors still grew despite the combination of drugs. But there were a handful of patients that have stability of disease, i.e. no tumor growth, and they had 4 patients that had partial responses. And what this means is that they had 4 patients that had greater than a 30% reduction in their tumor volume. Interestingly, 3 of the 4 responders were microsatellite stable, so they were not MSI high, and 1 responder had an unknown MSI status, and so they weren't able to evaluate whether or not that patient was MSI high. What this shows us is that the combination didn't necessarily work for everybody, but when you look at the combination of this targeted therapy with the immunotherapy, for the first time, we're starting to see responses in patients with microsatellite stable tumors. And that's why this combination is exciting. It's because it's a proof of principle that maybe we can refine this where we give targeted therapy together with immunotherapy, and it may work. Again, this is a minority of the patients, 17% overall response rate, but again, it's some of the first responses that we've ever seen in patients with microsatellite stable tumors. So the combo had a higher response than either drug alone. This is certainly encouraging preliminary results for, again, 95% of our patient population with metastatic colorectal cancer. And of note, a phase 3 study of this combination is actively recruiting right now. So one of our take-home messages that we want from the webinar is essentially to participate in clinical trials. Moving the field forward, is going to require participation in clinical trials. You're seeing some really promising results. I've shown you 3 immunotherapy trial results, and this is the only way currently to get these new drugs and to try them to see if they're effective against your cancer. We want to make sure that you know that a majority of trials are not placebo-controlled. In other words, there's not an opportunity to get a placebo. In many of these trials, you're guaranteed to get the treatment. Again, this is your first access to a lot of promising therapies that we believe and are hopeful that will be effective against colorectal cancer. And again, this is the mechanism to find the correct dosages, the correct drugs, and to push the field forward. And so we certainly encourage active participation in clinical trials if one is available. All right, we're going to switch gears a little bit. One of the more interesting abstracts that were presented at ASCO was this idea of whether or not the side of the tumor in the colon actually affects overall survival or progression-free survival. So we're going to show you results from a large trial that was done in the United States, including about 1,000 patients that received frontline therapy for colorectal cancer. And the big question that they were trying to answer when they did this analysis of this study was whether if your tumor developed on the right side of the colon or if your tumor developed on the left side of the colon, is there a difference in either overall survival or progression-free survival? We know that right versus left colorectal cancer is actually different embryologically. So what this means is that the right side of the colon actually develops from what we call the midgut when you're an embryo in development. The left side of the colon develops from what we call the hindgut when you develop in utero. We believe that there's a difference in prognosis, and we want to talk about what this might mean for patients. And so when we talk about the right side of the colon, this is a great schematic of kind of the right side of the colon versus the left side of the colon. What happens is as the small intestine turns into the large intestine, the first part of that large intestine is called the right side of the colon. And that includes the cecum, the ascending colon, and the transverse colon, which is this middle part of the colon. The left side of the colon includes where the colon starts going down, so that's the splenic flexure, the descending colon, and the sigmoid colon. And then, of course, down below is also the rectum, and so that's where rectal cancer develops as well. So this is the differentiation, again, anatomically between right and left sided colon cancer. We know that there's some clinical features associated with right-sided colon cancer. Patients that develop right-sided colon cancer are typically older at the time that they're diagnosed. Female patients are more likely to develop right-sided colon cancer. You have later onset of symptoms and a later stage of diagnosis, mainly because a lot of times it's hard to look at the right-sided colon because you have to travel a greater distance with a scope, and there are other screening tests like flexible sigmoidoscopy that don't even look at the right side of the colon. The right side of the colon has more difficult to detect polyps. They're more oftentimes flat, so they aren't raised like colon polyps normally are. When we look at these tumors under a microscope, they can sometimes look a little bit more aggressive, and they're more associated with metastatic disease to the lining of the abdominal cavity called the peritoneum. So when they did this analysis looking at patients that had left colon cancer versus right colon cancer, what they saw was an overall survival difference. It seemed like patients that had left-sided colon cancer seemed to do better than patients that had right colon cancer. One of the things that I want to mention here is these are all patients with metastatic disease or metastatic colorectal cancer. So none of these patients had early stage or stage 1 through 3 colorectal cancer. So all of these patients were stage 4. And so again, when you look at this, left-sided seemed to do better than right-sided. Interestingly enough, in patients that were treated with cetuximab in the frontline setting, the difference was even greater in terms of overall survival difference. So left-sided patients that received cetuximab seemed to do even better than patients with right-sided colorectal cancer that received cetuximab as part of their frontline chemotherapy regimen. And what I mean by frontline is the first chemotherapy that they ever received. And so the take-home message here was that left-sided colon cancers that developed on the left side of the colon seem to do better than patients that develop colon cancer on the right side of their colon. What we know is that, well, we're just looking at sides. What we assume is that the sidedness, left colon cancer versus right colon cancer, is not just that left seems to do better than right. We know that there have to be factors that are associated with either the right colon or the left colon that must explain why the disease seems to be more aggressive on the right compared to colon cancers that develop on the left. And so what this slide is essentially showing is that we know that there are environmental, genetic, embryologic, and even epidemiologic differences between the left colon and the right colon. We're going to go through some of the examples of why this might be that we're finding this difference. And what I mean by epidemiologic is that, as I told you before, it takes a colonoscope has to travel from the left side all the way to the right side. And so these tumors are harder to detect. And so is it just that what we mean by lead time bias is that are we just seeing the difference in finding a disease at a later stage? In other words, by the time we find a cancer on the right side of the colon, has the tumor already had time to grow? Has it had time to metastasize? Has it had time to metastasize to other organs besides the liver and the lung? And not only that, is it that we're starting the treatment a little bit too late in the game as opposed to a left-sided colon cancer where we're able to find it a little bit earlier because the patients are having symptoms that are more readily detectable, such as bleeding or even pain. In addition, we know that there are environmental differences between left-sided and right-sided colorectal cancer. We know on the right side that there's a higher concentration of bile acids. We know that there's a higher bacterial count in the right side of the colon, and therefore there may be higher levels of inflammation. This slide basically shows that we know that there are higher amounts of this bacteria called Fusobacterium nucleatum. And essentially what that means is that if there's more bacteria on that side of the colon, could there be more inflammation? And because there's more inflammation, the cancer develops a little bit more readily, and therefore you have slightly more aggressive disease and potentially worse survival. We also know that right-sided colorectal cancer has different mutations than left-sided colorectal cancer. We know that mutations that can sometimes cause a prognosis to be worse, like a BRAF mutation, is more present on the right side than the left side. So we certainly know that there are molecular features of this cancer that are different on the right compared with the left. So a lot of information, but in patients with metastatic colorectal cancer, what this study does tell us is that the side of origin does matter. And we know that the sidedness, left versus right, is simply a surrogate for tumor biology. And so what this means is that as investigators and as physicians, we certainly need to do a better job of investigating why these tumors behave differently, and it may help us to improve and individualize care in the future. All right, for the last study, I'm going to wrap up with something that I believe is fairly groundbreaking because we've never really talked about looking at tumor DNA in the blood. And so I want to show you results from a study where they actually took blood from patients and looked for tumor DNA to see if they could actually detect DNA from the tumor circulating in the blood. And this is going to be in early stage colorectal cancer. So we're going to talk about stage 2 colorectal cancer as opposed to stage 4 colorectal cancer. So as physicians and as healthcare practitioners, our job whenever somebody has a resected colorectal cancer is to assess their risk of having the cancer come back. And so what we're showing you on the left is a traditional approach. We take out the tumor, we kind of look at the features of the tumor, try to calculate out a recurrence risk, and then we have an honest conversation with our patients. How likely is it for your tumor to return? If the likelihood is very high, a lot of times we'll try to offer chemotherapy to prevent the cancer from coming back. If the recurrence risk is low, then we may not offer chemotherapy because the benefits are not, well, the risk may outweigh the benefits of actually getting chemotherapy. What the investigators for this study tried to do is when a primary tumor was removed out of the colon, they actually took a patient's blood and tried to detect whether or not there was circulating tumor DNA. And they have the technology to actually be able to detect this now. And they wanted to see, well, what happens if we do detect circulating tumor DNA, and what happens if we don't detect circulating tumor DNA? So what's interesting is that, again, tumors can release small DNA fragments into the bloodstream, and these aren't tumor cells, they're just DNA strands. And what we mean by circulating tumor DNA is that when we draw a vial of blood, we can actually look for these fragments of DNA, and if we see fragments of this tumor DNA, we can see if that affects their risk of having the cancer come back. So this is the recurrence-free curves for patients with stage 2 colorectal cancer. So all of these patients were not treated with chemotherapy. And what you'll see here is that if the investigators were not able to detect circulating tumor DNA in the blood, the patients had a 90% 3-year recurrence-free survival, which meant that a vast majority of the patients never had their cancer come back. Interestingly, they only detected circulating tumor DNA in 14 of the 178 patients that they investigated. But in the 14 patients that had circulating tumor DNA detected, all of them within 2 years had the cancer return, which meant that, again, if you were able to detect circulating tumor DNA in the blood, their risk of having the cancer come back was almost 100%. And so, again, this is an early study. This is not a randomized controlled trial. Circulating tumor DNA is certainly an experimental test right now, but this will definitely be something that you see investigators testing in the future, because the real question here, when you look at the 14 patients that had circulating tumor DNA, what we really want to know is, well, are these the patients that we should have offered chemotherapy to? In other words, are these the patients that are going to benefit the most from chemotherapy? And so the take-home point from this study is in patients with stage 2 colon cancer, detection of circulating tumor DNA does provide direct evidence of residual disease. So these patients did have their cancer return. And the real question, again, is can we use this data to determine who might benefit the most from chemotherapy? And can we start using this to actually select patients that shouldn't receive chemotherapy? In other words, do the risks of chemotherapy outweigh the benefits or vice versa? The last point here is that we want to encourage everybody here, as I encourage all of my patients as well, to seek care from a comprehensive cancer center. I always encourage my patients to seek a second opinion. This isn't about your doctor's ego or making sure that your doctor, you think that your doctor is the best. A lot of times I tell my patients, I always encourage you to get a second opinion, mainly because it's always good to get a second pair of eyes on your disease, on your treatment, and what possible treatment options are out there. If you're not near an NCI Comprehensive Cancer Center, most of NCI Comprehensive Cancer Centers do offer remote second opinions, where if it's too far to travel, they'll give an opinion and a recommendation based on what they read through your chart. And so this is available at a lot of NCI comprehensive cancer centers. So certainly take advantage of that as well. And just as a final note, a lot of the research that you're seeing is funded either through the NIH, sometimes it's funded by pharmaceutical companies, sometimes it's completely unfunded. One of the missions of the Colon Cancer Alliance is to promote research for colorectal cancer. It's the only way that we're going to push this field forward. It's the way that we're going to offer better treatments than the ones we have now. Our patients deserve much, much, much better than what we're doing for them right now. Research is it's what's behind a lot of the therapies that I've talked about, including some additional new tests like circulating tumor DNA. This SALA Foundation is matching research donations up until July 1st, up to $125,000. You can make a tax-deductible gift online, and the instructions are here on this slide. So again, certainly encourage that as well. I need to give a very, very big thanks to Dr. Porter, Dr. Schrag, Dr. Meyerhart, Dr. Eng, and Dr. Marcellet for their help in creating this, particularly Dr. Porter, who created a lot of the content that you're seeing on this slide deck. Thank you so much for taking time out of your evening to join this webinar and talk about some of the latest research. And I'm going to hand it back to Kevin, and I believe we're going to have some time for questions. Thank you very much.
All right, thank you, Dr. Liu. That was incredible, as always. We have time for some questions now. As a reminder, to submit a question, click on the small plus sign on the upper right side of your screen. You'll then type your question in and hit enter. And if we're unable to get to your question tonight, we'll respond to you via email. We have a few questions here. Dr. Liu, do you have to have exhausted both the first and second line to be eligible for this trial or that trial?
That's a great question. It varies per trial. A lot of times, the eligibility criteria for a lot of the MSI High colorectal cancer trials just require that you've had at least one line of therapy. There's, in fact, one immunotherapy trial that doesn't require any therapy. That's a frontline trial, so they're investigating the use of these immunotherapies. That's actually the first line of defense, if you will. But most of these trials do require that you've had at least prior treatment, but those eligibility criteria vary from trial to trial, and so, but most of them are kind of in the second and third line setting.
Thank you. I have a question here for Dr. Laura. Dr. Laura, how do you get your doctor to help you find a trial? Is it hard? Is it easy? How do you go about doing that?
Well, we at the Colon Cancer Alliance, we do have an agreement with they can go on our website and find clinical trial information. Also, I think one of the things to do is to ask your doctor. I think it's more difficult in smaller community settings than it would be in a large hospital. But for example, the TAPER clinical trial is through ASCO, and they actually are open in several smaller clinics, and they are taking all tumors based on the genomic analysis of the tumor. So,
okay. Dr. Tom, I have a question for you, and I'm going to try very hard to get this question correct. And get a little technical here. It's there's this questioner, this individual has a question, 3 efficacy E questions for Dr. Tom. E equals enoblituzumab equals a B7H3 monoclonal antibody, question mark. And the second E would be for ipacatostat. Is that an IDO1 inhibitor? And the last question is, the final E efficacy question is the entinostat a MDSC blocker? Dr. Tom? Okay, we'll come back to Dr. Tom when he can join us here in a little bit. Got another question here for just the expert panels in general. When it comes to immunotherapy, we saw that T cells are prevented from attacking a tumor. Do they know what the mechanism is that actually stops the T cells from attacking? Or is that goes to the core issue of immunotherapy?
Yeah, so it's actually a little bit of both. So the immunotherapies that are designed, and we didn't have a lot of time to kind of go over the mechanism of action, but there are numerous immune checkpoints that our body has, which are good checkpoints. That's the reason why when we get exposed to foods and other different things that are normal and good for us to take, our immune system doesn't react in an adverse way. And so the immune checkpoints are simply that. They're stops on our immune system to not go crazy whenever we eat, a steak. The tumor actually utilizes these same immune checkpoints to literally give the immune system a stop sign. Don't kill me. And that's what programmed death, ligand death receptor really is. And so essentially, if you have a drug that can bind either PD1 or PDL1, which is an immune checkpoint, you can essentially reactivate the immune system. But PDL1 or PD1 and CTLA4 are just two immune checkpoints, and they're numerous in the body. And so, this is essentially the basis behind immunotherapy, is that we know that tumors can evade the immune system. Can we try to essentially turn the stoplight into a green light and get the immune system going?
Okay. And I got a question here for the panel. If you have right-sided tumor, should your follow-up testing be more aggressive?
So another great question. I don't necessarily think that the data that we saw with right versus left should really automatically change everything that we do for right-sided colorectal cancer, but it should be a discussion with your physician as to whether or not the treatment that you're on is the best treatment for that. I don't think that we need to start individualizing therapy based on right versus left at this time. That's purely an opinion, one that other people may disagree with. But having said that, I think what the study does show us is that we need to better investigate why we're seeing a difference in the effectiveness of our drugs. And if we can figure that out, we may be able to better individualize and personalize therapy for our patients. But I would say we're still a little bit early based on what we know so far.
And I also want to add to that I was diagnosed with right-sided, and mine had gone through the wall of the colon, and it had engulfed a lot of my lymph nodes, and it had gone into my small intestines, and it was extremely extensive. And I was 43, and that was, almost 13 years ago. So even though it says that there's a lower, it has a worse prognosis, I don't want anyone to be, to be put off by that, because, it's all individual. So.
Yeah, and I completely second what Dr. Porter said. It's one of those things where you're looking at literally an analysis of 1,000 patients, and so certainly this is good data for us to know so that we can push the field forward. But again, individually, keep in mind that statistics are great at making 1,000 people turn into one person, and we certainly know that that's not the case. Every individual is different for sure.
And we're going to check in on Tom. Tom, are you back on the webinar here, sir? Okay, looks like we may have lost Tom, but that's okay. We have another question here. This one, there appears to be no clinical sites close to an individual who asking the question. He says, there appears to be no clinical trials close to me. Can I travel and in a couple cases have relatives close to the site? How does one apply? if they don't live locally, and he'd like to know if we could do a webinar on doing clinical trials, and that's certainly something we can explore. But he's looking for information on what to do if he doesn't live close to a clinical trial. Any suggestions for the asker of this question?
I'm happy to field that, and I'll let Dr. Porter weigh in as well. But we have a lot of people that get referred to our center, and this is true for a lot of comprehensive cancer centers, where, correct, I mean, sometimes our patients do end up staying with friends or family. Sometimes clinical trials, and I'm not going to say always, but sometimes clinical trials will actually pay for travel costs, or at least a portion of that as well. And so, travel and access to these clinical trials is certainly something that we're aware of. Different universities and comprehensive cancer centers also have funds that are also dedicated to this. And so certainly it just depends on what center that you're talking about. But these are all resources that are typically available.
Okay, very good. Tom, I see you pop back in. Are you with us now, sir?
Okay, yes, can you hear me now?
Oh, there we go. Welcome back.
Excellent.
All righty.
I've been listening the whole time, unable to talk.
All right. Did you hear the one question that we first addressed to you about the efficacies?
Yes. What I can say about that is that was 3 different drugs of 3 different mechanisms of action. I don't believe off the top of my head that they're being looked at exclusively for colorectal cancer or specifically, but they are being looked at in the clinic. I don't have much to add beyond that, but there are definitely 3 interesting mechanisms of action that are investigational right now.
Right, there was the same person had a follow-up question, and that was, in MSS versus MSI, is MSS versus MSI quantitative or qualitative? That is, could MSI mutations be lurking among MSS mutations, and therefore, if qualitative, maybe 1,000 MSI mutations, there are a few that also work for some MSS patients. But if quantitative, then is something else going on, based not on the type of mutation, but the number of mutations. Thus, a checkpoint inhibitor will never work for an MSS CRC patient.
Well, there is a range. It is semi-qualitative. There is actually MSI High, MSI Low, and MSS. What you can see scientifically is that within the MSS, 95% of patient population, there's actually a range of different disease subtypes within that, and some are actually somewhat MSI High-like in some ways. It's interesting to note in that 2015 study from ASCO, when they were looking at different colorectal cancer patients with a PD1 inhibitor monotherapy, and they saw a 0% response or objective response rate in microsatellite stable colorectal cancer patients. There were a couple of MSS patients that had stable disease, which I think scientifically looks like it may be, once again, sort of a qualitative middle ground between the two different subtypes.
Okay. And got a question here. Is there any value in getting a blood test to see how much circulating tumor DNA you have if you're stage 3 or greater? I mean, if you're greater, then you got metastatic disease, but particular stage of 3.
Yeah, I would say that right now that's a little bit still, well, very much so, still under investigation. I don't think that circulating tumor DNA is at all ready for prime time in terms of determining who should and shouldn't get adjuvant therapy. We just don't have enough information. But I think what you'll see over the next couple of years are clinical trials that surround this idea of, if we detect it, even in stage 3, what does that mean? The trial that I showed you was strictly only for stage 2 or patients with stage 2 colorectal cancer. So what I would say is right now, outside of a clinical trial, I probably would not act, well, I definitely would not act on any information regarding circulating tumor DNA, particularly for stage 3, because we just, at this point, we want to make sure that every patient with stage 3 colorectal cancer does get adjuvant therapy.
Very good. And I have a question that goes back to your presentation, Dr. Liu. In your presentation, you mentioned a blood test. Was the blood test you referred to the same as a CEA test?
No, so very, very different. CEA is a protein that we can detect in the blood that the tumor can sometimes express and release into the bloodstream. This is different. This is actually looking at fragments of DNA within the blood. So it takes a very, very specialized machine, and so different than the CEA. Okay.
And picking up a number of questions in here, quite a few. So in the interest of time, we'll try to high grade some of these here. Were there any findings at ASCO on diet, or is there any on the horizon that we could look forward to?
So I would say regarding diet, I think there are numerous studies that are going on. The biggest issue with diet is that every time we seem to look at it, everything that we kind of already know remains true, and that we certainly want to recommend a lower red meat, higher fiber, well-balanced diet. But dietary studies, including some dietary supplements that are used during chemotherapy and treatment, are always being looked at. In fact, some of that data is actually coming out of Colorado State University, kind of close to where we are, but nothing different in terms of that recommendation.
Thank you. And we have a clarification question here regarding the MSS study. Were all the 20 or so patients MSS, or were they a combination of MSI and MSS?
So the microsatellite, like the MSI High or MSS status, wasn't known for all the patients. What we do know is out of the 4 patients that responded very positively to the combination of drugs, we know that 3 of them were microsatellite stable. The 4th one we just didn't know. But I think that they knew microsatellite instability status for, I want to say, about 30 to 40% of the patients, which meant that 60 to 70% of the patients they just didn't know. But statistics being what they are, if 95% of our patient population is microsatellite stable, we assume that a majority of them were microsatellite stable.
Okay. Very good. And we got about 2 more minutes for questions. We're not going to get to all the questions, but again, if we don't get to your question, we'll reach out to you by email and make sure you get your questions answered. From the ASCO 16 meeting, do you see any expedient forward progress on using circulating tumor DNA, i.e. liquid biopsy, as a standard for those patients where tissue biopsy has been difficult or impossible to attain by conventional means?
I would say that right now, again, still definitely experimental. The gold standard is still to biopsy the tumor, but I think what you're going to see, again, in like coming down the pipeline, quite literally as we speak, are clinical trials trying to investigate that question.
Very good. And this individual heard of a monoclonal antibody drug trial using a drug called MORAb 004. Has anything been discussed at ASCO about that yet, or is it still too early?
I think it's a little bit early. I think that was the Morphotech compound. But I know that trial is still going on. I think the drug name is on tuxizumab, or I can't, but I think the number name is MORAb 004, as stated in the question. But as far as I know, I think that clinical trial is still ongoing. So I don't know if we have final results from that yet.
Okay, and this one's for both Dr. Liu and Dr. Tom. Regarding immunotherapy treatments, what are the concerns for patients with autoimmune diseases? For example, lupus, and is there anything in the pipeline for these patients?
Yeah, so I think I'm not a medical doctor, but Dr. Liu maybe can reinforce this. But I think a lot can be learned from the melanoma field, where these drugs are out in the market now and being seen by a broad patient population. Does that give some indication, Dr. Liu, of a path forward?
Yeah, so I think we all worry about it. I think the reality of it is probably better than our concern about it. And what I mean by that is that you'll probably see autoimmune diseases as an exclusion criteria for a lot of these trials. That's just because they want to be safe and they don't want to put patients at unnecessary risk. I think Tom is right. When you look at the melanoma data, the the risk of autoimmune diseases and these compounds is probably not as much as we would have thought. But it does become an issue when it comes to clinical trials because a lot of times that is an exclusion criteria. But I think the experience in melanoma has been definitely more positive.
All right, thank you very much. We are kind of bumping up on the 55, 56-minute time frame, and that means we do have some of our presenters who have to leave, and we do know that we didn't get to everybody's questions. And again, we'll reach out to you in the very near future and get you some answers to your questions. Thank you for posing those. Thank you, Dr. Liu, for showing up this evening and presenting. I know you got a scoot. Thank you very much, sir.
Thank you, everybody.
All right. As a reminder, everybody in attendance with an email tomorrow with a link to a very short feedback survey about this webinar. We value your opinion, and I promise it should only take a minute or two. We look forward to your feedback, and thank you in advance for your help. Some of you may have some questions you may want to ask in a more personal one-on-one setting. If you would like to speak directly with one of our certified patient and family support navigators, please contact them on our helpline at 877-422-2030 or visit them online for a live chat at ccalliance.org. Before we go, please consider joining us July 20th for our next webinar. It's going to be an all-Spanish conversations webinar series, Prevention, Detection, and Treatment of Metastatic Colorectal Cancer. Registration for this all-Spanish webinar will open soon. Please visit our website at ccalliance.org and visit the News and Webinar area located in the Get Information section and register now. I'd like to thank everyone for attending, and I'd very much like to thank Dr. Christopher Liu, Dr. Tom Marsolais, and Dr. Laura Porta for being on our panelists this evening. This webinar is being recorded, and all registrants and attendees will receive a link to that recording within 24 hours. And if you'd like to write to us, please forward your questions or comments directly to me at kbergerson@ccalliance.org. On behalf of the entire colon cancer team, I'd like to thank everyone for attending this webinar. I hope you found it informative and value added. Have a good evening and take care, everyone. Thank you for stopping by.